Hello, my name is Elmer. I'm one of the Neurocritical Care NP here at Keck USC, and I'm presenting aspirin in regards with neurology as a single antiplatelet therapy or dual antiplatelet therapy. As we know, aspirin is one of the first drugs to come into common usage, and it's still one of the research drugs in the world. Aspirin as a single antiplatelet therapy or dual antiplatelet therapy is mainly used as a secondary stroke or TIA prevention in neurology. An acute ischemic stroke is defined by World Health Organization as rapidly developing clinical signs of focal or global disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than that of vascular origin. And TIA or transient ischemic attack is a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. Of note, stroke does not equate to CVA or cerebrovascular accident because there are modifiable risk factors that patients can do to prevent stroke from happening. There were different studies that were done leading to the current recommendations for aspirin use as a either dual antiplatelet or single antiplatelet therapy for secondary prevention in treating acute ischemic stroke or transient ischemic attack. First, aspirin versus no aspirin, and the main studies that was done were the IST or the International Stroke Trial that used aspirin 30 milligrams versus no aspirin, and the CAST trial, which is the Chinese acute stroke trial, and they used aspirin 160 milligrams versus no aspirin, and it showed definitely a significant decrease in recurrent ischemic stroke with patients and reduction of further strokes, as well as the risk of further death in the hospital due to stroke. The next sets of trial showed the efficacy of aspirin as a single antiplatelet therapy versus adding dipyridamole as a dual antiplatelet therapy in secondary prevention for ischemic stroke and or TIA. Dipyridamole is a platelet aggregation inhibitor, which basically prevents platelet from sticking together. And the main two trials that is was vital for this are the ESPS2 or the European Stroke Prevention Study 2, which use aspirin um, and dipyridamole versus aspirin alone, as well as the SPRIT trial or the European Australian Stroke Prevention in reversible ischemia trial, which used a modified release dipyridamole plus aspirin versus aspirin alone, and it showed that the aspirin with dipyridamole is an accepted antiplatelet therapy, but for with patient with non-cardioembolic ischemic stroke or TIA, and possibly superior to aspirin alone. But the disadvantages of this study is that the dipyridamole has to be taken twice a day, and a lot of patients that are enrolled in this trial um, uh, complained of headache, which is one of the common side effects. The next set of trial showed the efficacy of using aspirin as a single antiplatelet therapy versus adding clopidogrel or uh, ticagrelor with aspirin as a dual antiplatelet therapy as a secondary stroke or TIA prevention. Clopidogrel is a platelet inhibitor, which actually inhibits the platelet P2Y receptor and subsequently the adenosine diphosphate mediated activation of the glycoprotein, which prevents platelets from sticking together. In Capri trial, which is the clopidogrel versus aspirin in patient at risk of ischemic stroke. It compared the efficacy of clopidogrel versus aspirin, and it showed for stroke patient there was a relative risk reduction favoring clopidogrel, but was not significant compared to aspirin. At the same time, long-term use of clopidogrel and aspirin showed similar rates of developing intracranial hemorrhage. Um, Aspirin had a higher rates of GI bleed. For match trial or management of atherosclerotic with clopidogrel in high-risk patient, it used clopidogrel and aspirin versus clopidogrel alone for secondary stroke prevention, and it showed no significant difference between dual antiplatelet versus single antiplatelet using clopidogrel in risk reduction, but with frequent life-threatening bleeding such as the intracranial hemorrhage and GI bleed in dual antiplatelet versus single antiplatelet. For SPS3 or secondary prevention of small subcortical strokes, it used aspirin and clopidogrel versus aspirin alone and did not show any reduction of stroke, but with doubled major hemorrhage on dual antiplatelet. For charisma or clopidogrel for high thrombotic risk of ischemic stabilization and management avoidance, they used clopidogrel plus aspirin versus aspirin alone, and it showed no change in severity of stroke outcomes. Finally, PROFESS or trial prevention regimen for effectively avoiding second strokes. They used aspirin plus extended release dipyridamole versus clopidogrel, and it showed broadly similar efficacy at preventing vascular events, but the dual antiplatelet has more major hemorrhagic events, such as ICH. Of note, these trial that I mentioned was long-term use of dual antiplatelet versus a single antiplatelet, and it mainly had a significant bleeding outcomes when it comes to using a dual antiplatelet for long periods of time. The next sets of trial showed the efficacy of aspirin, clopidogrel, and ticagrelor as a single antiplatelet therapy versus dual antiplatelet therapy in short-term use. So the CHANCE trial, or the clopidogrel in high-risk patients with acute non-disabling cerebrovascular events, it used clopidogrel and aspirin versus aspirin alone, and it showed reduced fatal of disabling stroke and ischemic stroke, but no increase in moderate or severe hemorrhage or hemorrhagic stroke, as well as this trial was conducted in China. The POINT trial, or the platelet-oriented inhibition in new TIA and minor ischemic stroke, used clopidogrel and aspirin versus aspirin alone, and it showed that dual antiplatelet um, has benefit for acute non-disabling cardioembolic stroke and TIA for short-term treatment. But both of these trials reviewed suggest that lack of benefit in longer term, but showed probable harm such as hemorrhage or bleed. Socrates or acute stroke or transient ischemic attack treated with aspirin or ticagrelor in patients' outcomes used ticagrelor, which is a reversible P2Y receptor antagonist, which unlike Clopidogrel does not require conversion from prodrug to active drug in the liver and is given BID. During Socrates' trial, um, patients were given ticagrelor versus aspirin for short term, and they showed more efficacy in larger artery disease and as well as preventing in primary outcome in patients who previously take aspirin alone. The most recent trial, which is Thales trial, or acute ischemic stroke or transient ischemic attack treated with ticagrelor and aspirin for prevention of stroke and death. Patients were given ticagrelor versus aspirin, and the outcome showed that the risk of stroke or death within 30 days was lower with ticagrelor. But the incidence of disability did not differ significantly between the two groups. It also showed some severe bleeding on patients that took ticagrelor. In addition, with ticagrelor use, a lot of patients reported shortness of breath and bleeding, and a couple of them were pulled out of the trial because of that. So for the current AHA recommendations in current practice and management for secondary prevention of acute ischemic stroke, dual antiplatelet was superior to single antiplatelet when started early and used for short-term regimen. But it also need to take into consideration the potential for an increased bleeding with dual antiplatelet. In addition, dual antiplatelet is not superior to single antiplatelet for long-term secondary prevention due to increased risk for intracranial hemorrhage and major bleeding. The current length of time for dual antiplatelet treatment after high-risk TIA or minor stroke for secondary prevention is from initiation to 21 up to 90 days. But the risk of bleeding should be considered and weighed against the potential benefits of dual antiplatelet for the patient. The latter studies for dual antiplatelets such as Capri, Match, SPS3, Charisma, and Profess trials showed that dual antiplatelet did not associate with lowering the risk of ischemic stroke, but it was associated with more bleeding events when dual antiplatelet is used for long term. Finally, dual antiplatelet um, showed significant efficacy in short-term use for secondary stroke or TIA prevention. So for patient that comes in with acute ischemic stroke or TIA with no recent aspirin use, the recommendation is to place patient on a dual antiplatelet, for example, aspirin or Plavix, up to 21 or 90 days, and then continuing aspirin alone. If the patient presented with acute ischemic stroke or TIA and is currently using aspirin, one strategy that we are using in our department is to use dual antiplatelet up to 21 or 90 days, then switching aspirin to clopidogrel as a single antiplatelet therapy alone after, due to the fact that the patient failed while on aspirin. Thank you for your time, and questions will gladly be answered at the end of the presentation.